Hi everyone, and welcome to this episode of the Lancet Pulse. We're really delighted to be joined today by Dr. Sebastian Försch and Dr. Inti Zlobec, two experts in computational pathology, and we'll explore what that actually means in the next few minutes. But maybe I could first ask you to introduce yourself, Sebastian first.
Yeah, hi, my name is Sebastian Försch. I'm a senior pathologist and a research group leader at the Institute of Pathology at the University Medical Center in Mainz, and I'm really happy to be here.
Perfect. And Inti?
My name is Inti Zlobec. I'm a professor of digital pathology at the Institute of Tissue Medicine and Pathology and director of the Department of Digital Medicine at the University of Bern in Switzerland. Thanks a lot for having me here.
And just so our listeners don't get confused if they hear me chirping, so Ben is leading on this podcast, but I'm Chloe Wilson and I'm here as well, and I'll be chiming in with a couple of questions as we go through.
Perfect. Thanks, Chloe. So we're going to talk today about a topic that you're both very familiar with, that's pathology, and, you know, in particular, the application of AI in pathology. And, you know, I think many of us are, you know, excited about the potential applications of AI in medicine. You know, even if there is quite some hype, it does seem like we're making some real progress in understanding where AI might be beneficial in, you know, in day-to-day clinical practice. And, you know, clearly some of the areas that we've seen the most progress in terms of AI has been medical imaging and pathology too. You know, why is that? And why are these fields particularly amenable to the use of AI? Sebastian, do you want to start?
Yeah, sure. I mean, it's an easy answer. Pathology is like the most important field of modern medicine. I might be biased in that a little bit. But actually, if you think about oncological patients, for example, most of the time, the diagnosis is either done by a pathologist or confirmed by a pathologist. So why is the combination of artificial intelligence and pathology so powerful? For artificial intelligence methods to be accurate, we need a lot of data, and we need a lot of good data. And in pathology, we actually have that. We can provide that. One digitalized whole slide is several gigabytes large, and we are seeing these cells and tissue under the microscope as close as possible. And we, for example, we're a decent-sized pathological institute. We are doing up to 1,000 of these slides each day. So there's a lot of data that can be used to train our AI models. We also have high quality data when you're looking at, for example, molecular pathology. It cannot get any closer than that. Using NGS, next generation sequencing, you have the molecular information of our patients, and together with powerful artificial intelligence methods, this can be a really, really powerful combination. I think this is why we're seeing the progress in that field.
I think it's also that, if I can chime in, AI works really well for visual data. So pattern recognition is a task that is very amenable for AI, and radiologists have done it a little bit before pathology has jumped into the game, but we can already see how well that works. And as Sebastian was just mentioning, yeah, the data are becoming more and more available because pathology labs around the world are now digitizing. And that's also a big, big change that's happening. So rather than looking at slides under the microscope, you can put them into slide scanners and you can actually look at them on the computer. So that's a really huge step that pathology has taken. And it's pretty much the basis for being able to build AI algorithms on.
Maybe we should go back to basics then. That's a good point to remind our listeners what these different terms mean. So we talk sometimes about digital pathology, sometimes about computational pathology. What is the difference, Inti? Maybe you can tell us between those terms. When does digital pathology become computational pathology, and what's the role of AI in all of this?
Sure. So it is true that a lot of people use these terms interchangeably, but that's not necessarily the case. So I would say that digital pathology is really about how you view your tissues digitally and the whole process behind getting those tissues to be viewed. So the digitization process, the management process, the workflows in the lab, whether that's for clinical use, but also I just also like to take that a little bit more broad. For instance, it's not only about taking that microscopic slide and digitizing it, scanning that, and being able to view it on the computer. But I would say that also applies to other areas that are not diagnostic, like, for example, other kinds of 2D or 3D types of tissue, that visualization methods. So we can, of course, talk about that later. But so I would say digital pathology is more about how you see the tissue and the processes of getting that tissue to be seen. And computational pathology is really more about the quantitative analysis, the extraction of biological and clinical meaningful information from that tissue. So it's really about how to understand the tissue, how to analyze the tissue. And that's where AI comes in. So AI, your sort of AI tools are computational tools. So you would need digital pathology to be able to run those AI tools in a computational way on the tissue.
And I mean, it's clear then that pathology is undergoing quite a bit of a shift compared to where it was several decades ago in terms of being able to digitize those images, but also analyze the images with AI. Sebastian, maybe you could tell us, what you think some of the big shifts have been in pathology in the last few years.
So in pathology, there have been tremendous shifts. For example, it started this is a little bit of a history lesson. It started with the introduction of immunohistochemistry, for example, being able to detect expression of certain molecules within the tissues. Then one big shift, of course, was molecular pathology, being able to use new sequencing technologies to get information about molecular alterations. And as Inti just said, I think that computational pathology or digital pathology as a prerequisite for computational pathology is sort of the next fundamental shift. And these three aspects together make this so powerful.
I think it's also been referred to as the third revolution in pathology in some articles.
It sounds like the field of pathology has completely embraced technology. But are people nervous about some of these new technologies and artificial intelligence too? Are there cautions or things that people are worried about or things that aren't working so well?
Yeah, I think we are biased in that. You have some really technical nerds sitting here that are actually embracing this. We can talk about how this sort of affects the pathology workflow, which tends to be more on the older side. And there are certainly colleagues that are hesitant to do that much of embracing as we are doing here. So I think that's why this podcast is a really good chance to advertise for people who are hesitant. And of course, it's important to look at risks and limitations here as well.
I think maybe possibly the fear is on the one side, learning the new technology, right? And there's also, we've seen a few surveys coming up, around the world. And I would say a common characteristic is the fear of de-skilling. So that pathologists might be maybe over-reliant on these technologies and therefore are losing their ability to perform their jobs well. So that seems to be a fear that is out there. And the question is always how to be able to include these new paradigms, these new AI shifts into the daily work with, keeping an eye on exactly those challenging topics, like the de-skilling or like the biases and many other factors that come in. It's a new open field, but it's true that not everyone is totally embracing. There are a lot of skeptics around, but there are a lot of enthusiasts too. And I'm sure there will come to there is a middle ground for sure.
That's an excellent point. And I think to add to that, it's really important that during the development of these technologies, the people that are actually then applying it in daily routine are actually on board, and that this is sort of developed together. This is why we are embracing sort of interdisciplinary teams where computational scientists, pathologists, medical experts are sitting at one table to try to develop and then implement these new types of models.
I think the de-skilling piece is a really interesting one. And actually, we've seen that in some other fields, AI-related fields. So I think one of our journals recently published a paper on de-skilling as it relates to AI-assisted colonoscopy. So it's really something that I think, probably need to keep an eye on in this setting too. So, Sebastian, you said you wanted to advertise the pros of computational pathology. Tell us then, what can you do with AI in this space? What kind of things can we do in terms of computational pathology that we couldn't do a few years ago?
Yeah, so it's really important that most of the developments that we are seeing at the moment are proof of concepts. So The translational aspect is something that we have to improve upon, but sort of we have three fields where we think that the combination of pathological data, pathological knowledge together with artificial intelligence can be really powerful. So the first thing that we are exploring is using artificial intelligence to actually help pathologists to make their diagnosis more accurate, faster, even in the realm of rare entities, for example. And the second thing, and this is what we are being asked increasingly, and this is why pathology is so important, is that we think that you can use artificial intelligence together with pathological data to make a prediction on how a disease will progress, for example. So prognosis prediction as well as prediction of therapy response are other aspects where I think that the combination is really the next step to go forward.
Maybe also just to add on that, I guess on the one side, the AI tools that are somehow being developed right now, a lot of them are made to sort of replicate a little bit what pathologists are doing, but there's so much more that can actually be done, because once you have the data and they're quantifiable, actually there's a whole world of discovery. So it's not only about, building tools of today to sort of replicate what is being done, but also to go much further and see if there's a discovery potential there for developing even better diagnostic tools or prognostic tools and so on.
And you mentioned, Sebastian, that translation was a barrier. Are these systems being used in routine clinical practice now, or are we, as you said, still very much at the proof of concept stage?
So, I mean, this goes back to what Inti said in the beginning. So in Germany, for example, we are lagging a little bit behind when it comes to digitalization. So there are only a few institutions that are sort of on the forefront of digitalizing routine pathological specimens and slides. So I think this is something that is sort of hindering us from doing this translation. I think we have, with really highly published proof of concept studies, we have seen sort of what is possible. And now we really have to identify, after some of the AI hype dust has settled, identify the actual use cases where it actually helps doctors and actually improves patients' outcomes, which should be the main target of doing this exercise. AI for AI's sake is not something that we are fans of. We have to identify where it actually helps doctors render better care to the patients. And I mean, some of the nitty gritty aspects would be validation. So you need to show that your models are not only working in the Pathological Institute in Mainz, but also in Switzerland or UK or anywhere around the world, particularly regarding populations that are underrepresented in the data, for example. This goes to the bias aspect that Inti has mentioned. So validation is one key aspect. And then you have to do it safely. You have to take care of the really sensitive data that we are training our models on and that we are applying these AI tools on. It's medical data. It has to be protected. We in Germany are very strong about this. We feel very strongly about this, but I think that there's a middle ground where you can actually make use of these powerful technologies, but do it in a safe and a secure way.
And Inti, I mean, you touched on this idea of discovery before, and I'm quite fascinated by this idea that, and we know this is true now, that AI models can see things that the human eye can't see, patterns in medical images, and then can, predict various outcomes and so on. But are these systems telling us new things about, cancer biology, for example, or disease biology more generally? Are we learning things about diseases that we didn't know before through AI?
Yeah, I think that's basically what everyone is expecting to see and hoping to see, and the potential is definitely huge there. So when you are using these kinds of tools, of course, as I mentioned, you can either train them to identify features that we already know, or you sort of, let the system do its thing, let's say, from beginning to end, and then try to identify areas within those images that might be responsible for a prediction. So you can actually see from the image, if you're trying to train a model to help you predict patients who might respond to a certain therapy, and you have a huge amount of these number of patients who have either had a good response or a bad response to that particular treatment, you can, in a way, use these methods to try to build algorithms that will help you also to identify the new biology or the areas within that image that caused that prediction. And now the question is, how can you go back to that image and try to understand and interpret what that machine or what that AI algorithm has actually seen? And I think that that's very tricky in the sense that you hear about the explainability or the interpretability of AI algorithms. On the one hand, when I speak to my colleagues, they're not necessarily interested in knowing the details of how the AI system architectures work. What they really want to know in the end is, why is this prediction being made? Because they have to sign their name on the bottom of a report, potentially, and take responsibility for whatever is that prediction. So it's still, I would say, early days where we would learn something very new that would come from this kind of a system where the algorithm is pointing basically to areas and you have to try to interpret those areas. What we have seen, though, in a much more simple sense, would be, for instance, looking at relationships between cells. So, for example, we have a group of cancer cells that might be surrounded by immune cells. And now there are definitely works showing that the spatial proximity between those types of immune cells, so CD3, CD8 positive lymphocytes, and the cancer cells together within their spatial distances is actually a new prognostic factor, which might outperform just looking at the tumor-related features or just at the tumor microenvironment-related features. So I think that's a good example to show very concretely that many studies are showing this. This is being validated. And in fact, I would just like to say that a pretty early form of that type of algorithm was in fact published in the Lancet many years ago. It was in, I think, 2018. It was that big Immunoscore consortium validation. I think that might have been the first study looking at digital biomarkers in a multi-center validation study that actually led to a product. So my group was also involved in this study. That's why I'm picking up on it right now. But I think that might have been an early form of looking at the distribution of lymphocytes within the tumor areas at the invasion front and within the center of the tumor in colorectal cancers, which really showed very early that picking up this information digitally was very valuable.
I think the key aspect that Inti mentioned, if I can also add to that, is the explainability part of it. So even for these end-to-end models, we always try to implement explainability methods that sort of increase transparency and that can give you a sort of a sanity check of your model. But as Inti mentioned as well, it can also then, if you're pretty sure that your model is working correctly, it can point you to things not necessarily that not apparent for a human, but that you have not paid close attention to. So this is a new aspect. We have seen similar things in when we are sort of trying to infer molecular alterations from how cells and tissues look under the microscopes, or using H&E slides to predict molecular alterations. And there are some models that perform rather well on these. And then you go back and you look at the actual features that the model has used to get to its decision. You can learn new things. You can learn new morphological criteria that are associated with a certain certain genotype that is also relevant for treatment decisions. And you can actually, we have done studies where you can actually use these features and train pathologists on them. So the first time that we saw that you can actually learn something from the machine, which is a rather provocative thing to say.
I'm just kind of interrupting with a few thoughts. I think it's interesting. You explained it really nicely, because I think, so I'm one of those people that I'm probably more on the hesitant side of AI, which is why I love kind of learning about it. And I do think that probably some of the skepticism and the reluctance comes back to that aspect you said on responsibility. You know, if you're signing your name to a report, which is then on that aspect around trust of AI and understanding how the model works. And I think it's quite a difficult concept to wrap your mind around, either as a clinician or a non-clinician, the whole kind of computational and AI world for how it works. I think, at least for me, it's kind of often felt quite outside of my comfort zone, and realizing how it came to an answer, and then taking responsibility of that. It's just embedded in that aspect of trust, isn't it?
What's also really funny is, so we did this survey when I was chair of the European Society of Pathology Working Group for Digital and Computational Pathology. And we did this survey at that time together with our SDIP colleagues, so the European Society for Digital and Integrative Pathology. Long names, I know. But we did a survey, and we took advantage of the fact that we had about 200 pathologists sitting in the room, and we did a real-time survey to have a look at our colleagues' level of, let's say, exactly all these topics: trust, how much do they need interpretability? And what was really funny was that only if I could say it, I was very surprised. I assumed all pathologists wanted to have that interpretability. But only about, I think it was maybe 60% felt like they really needed to have some explanation for the result that the AI was giving. And then at some point I thought maybe this was a difference in definition. Maybe we were talking about different things when we were talking about explainability and interpretability. But when I speak to people one-on-one, some will say, well, if the tool is validated, just like our immunohistochemistry is validated, if it's validated, I will trust it. And that's good enough for many people to kind of overcome that barrier. Whereas others really want to see, the real, let's say, value, quantity and be able to see it for themselves. So it's really interesting. It's also similar maybe to getting a molecular report back, because they have just a gene mutation, right? You have a V600E mutation or not, but you yourself probably did not look at the sequence. So maybe this is somehow a parallel to that.
Yeah, it's a really good point, because, we do trust in the readouts of, even just getting your, a simple kind of blood test. You presume that always your white blood cell count, your hemoglobin levels, they're always going to be completely accurate. And we just trust in that. Probably most people don't even think about how you even get to those results. And that's just become embedded that you trust it. Or we never think if you have got, a blood sugar reading that seems a bit out of the ordinary, you don't often kind of jump to blaming the technology. So I think it's an interesting kind of hurdle to get over in your mind, I think, when we start thinking about AI compared to other things in medicine that we kind of just take as a given.
You need to have faith, Chloe. Faith in AI.
Maybe it's a little bit comforting. So even us people that are doing the research on that, I'm jumping back from the comfort zone to the non-comfort zone several times a day. And when new studies are coming out, I think what's really important is what the combination, the validation aspect and the explainability aspect, because explainability can also sort of help you to identify where your model can be completely off. So there are examples where looking at how the model reached a certain decision actually demonstrated that it was looking at completely different things and other things. We did a recent case study, where we looked at how sort of generalist models like ChatGPT type of models are affected by artifacts, for example, normal pen marks that you're writing on slides that can completely confuse the models and make it completely forget morphology, and it just will focus on whatever you're writing on the slide. And usually you would hope in a clinical setting that this is correct, but this is not necessarily the case. So I think it's really important to keep a clear head, take all these emotions, put them somewhere else, and sort of try to evaluate where it's actually helping us, but also try to understand the risks and limitations as well as possible. And this is sort of the sweet spot where you want to find. And it's rather tricky, but this is what we are aiming for.
And it's also dependent on the task you want it to perform, right? So if it's a matter of, for instance, counting cells, counting cells is a very simple task. And then you have to wonder, well, what happens if it's off by a few cells, or too much or too little? Does it really have a consequence at the end of the day? If the answer is, well, not so much, then it's okay. Somehow you can deal with that. But if it's, taking an image that, and from this image, it's a, good prognosis, bad prognosis is the outcome, and you don't really understand why, then, if a patient might really have a clinical decision that's changed because of that, and you don't understand it, then that's where the conflict really, really lies with many people, is how to handle this kind of a situation, who might be liable in the end. So it's your responsibility.
But on the other hand, it's also if you have an AI tool that controlled and studied setting can help to improve patient care, it would ethically not be okay to not use it. Yeah. So there's also, you can convert this argument in the other way around as well. Yeah. So, it's there are a lot of unanswered questions that we are trying to answer one by one.
We've touched a bit on, challenges around the workforce and their willingness to adopt AI and what they would need to see to be able to kind of adopt AI. Pathology is one of those specific disciplines within medicine that faces, particular workforce challenges. At least in the UK, I know that's certainly true. There's a far greater demand for pathology services than there are pathologists available. Do you think AI will really make a dent here in terms of addressing this workforce gap? And how do we ensure that pathologists are really well equipped and trained to make the most of AI's potential benefits and understand its pitfalls as well?
I think this is one of the key tools that we can potentially use together with digital pathology in the first place. So in Germany, we have a similar situation. The average pathologist is, I think, close to 60 years old. So we are walking right into that, and pathology demand is only increasing. But I think that digital pathology can attract young talent as well. So it's not only the technical nerds that are sort of attracted by that, but it could be that you allow flexible and new type working concepts, where there's no practical reason, or at least no theoretical reason why I could not be doing my diagnoses from I don't know, the mountains or the beach or wherever you would like to hang out. And if I have a tool that, going back to the AI side, that just sort of takes even 20 or 50% of my work, I would be happy to use that tool. If it's validated, if I know what the tool is looking at. So I think this has a huge potential if we are getting this correctly. And might be one of the few chances that we have, to keep up the level of care that we are currently providing in modern medicine.
We see, for instance, in our institute, so it's also about workflow efficiency. So we ourselves have a lymph node metastasis detection algorithm that we're using that was actually an in-house developed tool. Our pathologists are using it right now. It's more of a second look. So it's more of not the first screening, because we're not playing this game, but it's really about the verification, the QCing of those lymph nodes. And we can see, if, for example, a colorectal cancer case might have up to 70 lymph nodes sometimes. And how meticulous our pathologists need to be to detect, those even small little lesions in there. It takes so much time. It's a very laborious task. So why not have a system that can just double check that nothing was missed? And in fact, the one that we have working is already very, very accurate in the sense like we've never seen a missed lesion or a missed tumor area. So I think this is really helpful in that sense. Also to gain workflow efficiency. Of course, this would free up more time, maybe to have more time dedicated for other things or more cases. But I think the flip side of this is the digital literacy, that people know about the use of AI and that they know about the pros and cons, that they are familiar with the terminology, that they question the things, that it's not magic, right? That it comes from a place that needs to still be checked, validated. And of course, one area we hardly talk about these days, but we should, because it's maybe early days, because we're not at that level yet, but the post-deployment monitoring. How do your algorithms stay accurate across time is something that is hardly discussed within our pathology circles, at least not in the ones that I'm in. And also about habits, I would say, because there are, of course, different kinds of biases that pathologists themselves will notice. There is one thing that's been documented as automation bias. So you kind of just get used to the fact that AI is going to be doing your diagnostic for you, and you just agree with what the AI is giving as a result. And the other thing is the confirmation bias. So you already come with a thought about what that diagnosis might be, and the AI will confirm it. So even if it's kind of wrong, you might fall into traps that way. And I think it's very important that people are just educated in the possibility that these things could happen, that they're aware of it, not to just take it with a grain of salt that now AI is here and is going to solve their problem.
Well, before I forget, because just when you mentioned about validation, it came back to me something you'd mentioned just on the data sharing aspects, because I think what we do need is more collaboration between various different centres globally. But it sounds like there are definitely some challenges with sharing data between different places and having that validated in various different settings. I mean, is that a challenge that you see that we're likely to be able to overcome in the coming years? So I think that's what we're going to need, isn't it, with bigger studies and more data from various different places.
Yeah, so coming from Germany, where we are particularly proud of our really, really, really strict data protection laws, it's really, really difficult and something that is sort of we have to deal with each and every day. Yeah. So born from that, we actually are seeing developments on the algorithmic side of things, where when you cannot share the data, you maybe can share the model progress, where you cannot see any or infer any data that has to be protected. So this is something called federated learning or swarm learning. There are some sort of very intelligent workarounds, but on the other hand, of course, we do have to find ways to train these models on the data, because if you ask the patients, actually, that is what most of them actually do want. So in Germany, we have cancer registries, where you can actually say, okay, I don't want my data to be used for research, and I also don't want to be contacted for if there are new treatments that are arising. And these, at least from what I've heard, these cancer registries rarely receive any sort of, I don't want my data to be used. Because the patients there, if you are sick, you want to get healthy again, and you want to support everything that helps doctors to improve care. And this is, in some aspect, can be sharing the data for the models to be trained on. I think we'll add this to the list of difficult and unanswered questions that we currently have to work on.
We also have the problem just between our university and the hospital to share the data. So, I mean, that already gives you an estimate of how that's a very, very challenging topic. It's definitely one we need to find better solutions for, but how to do this best is still, as Sebastian mentioned, it's a difficult topic.
Yeah, and I've heard that from people in other, digital health areas as well. One of the biggest challenges is the infrastructure around access and sharing of data.
And the one thing I just want to maybe mention on this point is, like, if you see also where the future is going, right? Not only pathology, but we're talking about multimodal data, how to get the best information across different disciplines. So we're going to be working with imaging data that might come from a variety of different sources, so it's not only from one institute or one department, but really across various departments, whether it's radiology or nuclear medicine, or maybe even cardiology, or, sensor data or signals from somewhere, and how to be able to work with all of that different data. Of course, we have to be, reasonable with the data protection laws. I mean, of course, we have to do this. But at the same time, it would be a missed chance not to be able to use the data that are available from across the different disciplines. So there really has to be also a way to take care of that. And these data are huge. Let's also not forget. I mean, our own data in pathology is huge. But if you start to combine it now with a variety of other kinds of data across the board, are we ready for that? The compute power, the IT infrastructures, all that goes together. And it's been a real barrier.
I don't envy you having to deal with the challenge. So maybe we could finish by looking at, where you think the field is going in the next 5-10 years. What should researchers, clinicians, what should we as a journal and, other stakeholders in all of this, what should we be keeping our eyes on? Where is the field going from here?
So from my point of view, I think that what we really, really need to see are the real life implementation of these AI solutions into real diagnostic workflows. So one thing is the research, and yes, we can obtain very high accuracy for our algorithms, and there's always someone chasing that 0.5, higher accuracy that you can get on a model, but the real life implementation and having quantifiable measures of change. And in the end, saying that these workflows are X amount more efficient or produce, a true impact for patients, as Sebastian mentioned earlier, right? To have that measurable difference in patient outcomes. That would be my first point. And the second point I would imagine is that we should be also on the lookout for new technologies, multiplex immunofluorescence, for example, or even 3D technologies, because there I think it's really fascinating. We're at the point where we do have better high performance compute power. We have those storage capabilities. We can now deal with massively huge types of data. And I think the 3D tissue imaging is going to reveal, as coming back to your original question about the basic science or translational aspects, we're going to learn a lot, I think, from those kinds of different modalities.
Sebastian, do you want to add anything?
Yeah, that's absolutely. There's hardly anything more to add to that. So I think we still have a long way to go. Yeah, I mean, we have quite a good understanding of what AI might be capable of. Now it really goes from proof of concept to clinical implementation. So identify the use cases where it actually makes sense and actually helps doctors and helps the patients. And all of the other stuff that we have said, keep it in mind. Keep it in mind that you have to validate your algorithms, that you have to be transparent and explain them, and also keep data protection and securities and risks and limitations in mind. I think this is sort of the framework that we are currently looking at.
Perfect. Chloe, did you want to ask anything else, or?
No, that's great. I think it's a really nice note for us to end on. I'm feeling cautiously optimistic.
We can agree on cautiously optimistic.
Thank you both so much for your time. It's been a great chat.
So I thought that was really interesting. I think that it was a good discussion and quite a realistic discussion of where we actually are with some of these tools and what the future of them might be. Because I thought they were very realistic. I mean, often when we talk about AI and whichever specialty it is, whether it's radiology or if it's pathology like this, we sometimes discuss it in an all or nothing type of way, don't we? Whereas I really liked it when Inti kind of broke it down and said it very much depends on the task that you're asking AI to do. Because if you're asking it to make a clinical prognostic decision, that's quite different than if you're asking it to count the number of cells, for example. And I think that's a good thing to remember, or definitely a good thing for people like me who are often a bit skeptical of AI to think about.
Yeah, I mean, I think being aware of context and task-specific challenges and pros and cons of using AI is obviously going to be super important. I think, a few things struck me, and we spoke about being science nerds, but I think from a technology point of view, I mean, it's really, as someone who loves science, it's really quite remarkable what these systems can do just in the context of cancer. So can identify different regions of tumors, grade tumors now. They can, predict biomarker status or different molecular alterations from just a H&E slide. Like, clearly there is so much more information contained within that slide, that H&E image, than the human eye can see. So really the ability of AI to extract kind of hidden information from these images is really quite cool, I think. In terms of the clinical application, yeah, I mean, it's obvious the ways in which AI might be able to alleviate some of these kind of laborious tasks for human pathologists, alleviate the workload, and potentially just triage cases for more urgent review or confirmatory molecular testing, or standardized testing across labs or clinical trial sites. But it's clear that, we're not in a situation where we're ready to let AI go off and do all this on its own. It's quite clear that the pathologist needs to remain in the loop and in control, and ultimately, as we said, kind of liable for these decisions that they're making.
Yeah, and as they said, it's not about using AI just for the sake of using AI, but really thinking about where its implementation might be most useful. And I mean, I'm definitely not a surgeon, but I remember when I was working in ENT and we did quite a lot of head and neck cancer cases, and you would be there in surgery and you'd be waiting after you'd sent, a sample over to the pathologist to to know like what your margins are looking like, and sometimes that took a really long time. It could be quite difficult in some hospitals, with a district generals when it goes to after 5 o'clock and some of these things are taking a really long time. So you think that if you have tools like this that can help you make real-time decisions much more quickly, how much of a benefit that can actually make to an individual patient, because I think we often think about pathology as being confined to a lab, but actually the link, as you said, with cancer and with surgery is really something that I don't think we think about as much as perhaps we should. So I think there's huge possibility for these tools, but I'm not sure we're quite there yet. And they definitely need a lot more refinement, but I'm excited to see more of these types of studies.
Yeah, and I guess following on from that, what we might be thinking of as of interest to the Lancet was some of those studies that we were talking about at the end then. So I think at this stage in this field, at this point in time, we know quite a bit now about what AI can potentially do. And some of the challenges there, but we want to see these things happen now in practice. So, show us the prospective implementation of these tools in routine clinical practice and how this makes a difference, ultimately, ideally in terms of patient outcomes. At times, it might be relevant to conduct a clinical trial, an RCT. That may or may not be the right, design depending on the question you're asking. But we really need to see these tools implemented now and the difference that they make to patient care.
Yeah, definitely. And I think what I want to see is that, I know we talked about it a bit on some of these issues around data sharing, but they are massive hurdles and we absolutely should be protecting people's data to the most, adhering to all of the policies and really making sure that strong policies are put in place to protect that. But I am worried that we'll end up working across various different silos and that you can see how different hospitals and different universities within a small space will be using different models or using them, in a way that isn't coherent across a wider space or wider contexts. So I think we do need to be aware of that, because we know that with more data, these models are going to get better, but it's how we can do that in a way that does protect the data. It's a big challenge. I think it's probably one of the biggest challenges, along with actually, overcoming the technological hurdles. And,
I think to that end as well, I'd be quite keen to see those large scale, multi-country, multi-center studies that demonstrate that some of these systems really are generalizable, reliable across different populations.
And it is possible, because we have seen it, haven't we? We've seen large studies that have validated different models across different countries. So it's definitely possible. But I know it's a big challenge. But I think that's one of the big next steps, along with the trials, is making sure that the models are generalizable. And if they're not, why aren't they? And then how can they be adapted to make sure that they are?
Exactly. Yeah, I agree. Shall we wrap up?
Yeah, I think that's good. I think we've both come away feeling cautiously optimistic, and I'm definitely looking forward to seeing more of these types of studies now.
Thanks, Chloe, for joining me today, and thank you very much for listening.
Thanks, bye.
Thanks for listening to the Lancet Pulse. If you enjoyed this show, leave a rating or a review on your favorite platform and subscribe to stay updated on our latest episode. The editorial team includes Chloe Wilson, Ben Abbott, Matthew Gilbert, and Jonathan Pimm. This show is part of the Lancet Group podcast offering, and it's produced by Matteo Simonetti. Thank you for being with us.